Panelists not yet joined, isn't it?
Yes, ma'am.
Hello.
Hello, Dr. Subodh.
Yes, I am there. Good afternoon.
Yeah, good afternoon. How are you?
Fine, thank you. Hope you two are fine.
Yeah. Maybe busy with your works and all in the institute.
Right now we have only 25 participants.
Subodh, not yet. You didn't on your video.
I've turned it on. It's there. I am there on video. I am there.
Okay. Good afternoon, Arun Kumar sir. A.K. Chaudhary sir. Yeah, now it is visible, your video. Rohit, have you muted everyone?
When whoever is going to join, they have to unmute themselves and they have to speak now. To avoid disturbance in between the presentation, I made this arrangement so that whoever joins, they have to unmute to speak.
Oh.
I think we don't have.
No, A.K. Chaudhary sir usually responds. So he could not able to unmute or.
Should I give a roll call now or should I wait?
No. When we start, after me welcoming everybody, you just take the roll call and introduce the panelists.
Okay, before introducing.
Yeah, before introducing panelists, so just take the roll call of all teams.
Okay.
Or after introducing. Okay.
Right now we have some time. If you want,
No,
I can.
it is not. We have to start the session, no, 4 o'clock. So just now, 1 more minute is there.
Once I introduce the panelists, then I will.
Yeah, that's better. And if you have the table of the ask the team people to switch on their video and show their faces also. Teams, you read out the institute names. You think you have the list of team members and the institute name.
I do have the list, ma'am.
Yeah. What is this? The lines on the screen?
Maybe right now,
Red lines came. Huh?
maybe somebody is using to draw, ma'am. I will just, and I mean, disable them.
On your screen it is there or only my
Oh,
screen?
maybe on your screen, I think.
Okay, okay. Then it's no problem.
Good afternoon, ma'am.
Good afternoon.
How are
Sir,
you, madam?
I missed you. I don't know what happened. My audio is correct only. How are you, sir?
Hello, madam. How are you?
Fine, sir.
I'm
How are
good.
you? Your video is not on. Huh?
Yeah, now is it audible? Are you able to see video and
Please
audio?
just
Yeah.
see. Good afternoon, Ramnanan sir, Ramesh sir.
Good afternoon, madam. Good afternoon.
It's 4 o'clock. Shall we start the program?
Yes, madam.
Good evening, all. I welcome all of you to this today's fourth session of Apsicon 2024 online Plastiquest competition. I welcome our patron, Dr. V. Bhattacharya sir, and Zoom platform sponsor overseas faculty, Dr. B. Venkatratham garu, and today's panelists, Dr. Ramanandan sir, Dr. Nikhil Panse, Dr. Subodh Kumar, and Dr. Ramesh KT. All are experienced teachers in reputed institutes, experienced in the field, and they are in PG teaching. So we will have a good session today on flexor tendon injury and other components. We have PG team from Stanley Medical College going to present their cases. And I invite all the Plastiquest faculty and PGs for today's session. And I request our co-organizer, Dr. Rohit, to take the roll call and introduce the panelist formally.
Ma'am, should I take the roll call first, ma'am?
Yeah, you can do that so that all teams, they are present or not, you withdraw the presentation and let the team PGs switch on their videos and say their presence.
Sure. Team 1, Madras Medical College.
Yes, sir. Present, sir. Present, ma'am.
Yeah, fine. And team 2, Jipper Pondicherry.
Present, sir. Present, sir.
Fine. And team 3, KGMC Lucknow. Do you have anyone from KGMC Lucknow? KGMU Lucknow.
Present, sir.
Present. Okay.
Switch on your video. Okay.
Hello. Hi, madam.
Good evening, sir.
Good evening.
Pancha sir, ma'am.
Huh?
And, team
Good evening, Dr. Nikhil.
Good evening, ma'am.
Just we started the program and I welcomed everyone, and we are
Right.
taking the roll call, and later Rohit will introduce everyone. Okay, Rohit, carry on.
For Stanley Medical College.
Sir, we are present, sir.
And team 5 AIMS New Delhi.
Present. Present, sir.
And team 6 Bangalore Medical College.
Present, sir.
And team 7 CMC Vellore. Anyone from CMC Vellore?
Yes, sir, we are present.
Team 7 CMC
Hello,
Vellore.
sir. Yeah, we are there. Hello.
Oh, Prashant.
Yeah, Bala Prasad, we are there.
Sure. And teammate Saftajang New Delhi.
Present, sir.
Sri Krishna. Okay. And team
Yes,
9 RML New Delhi.
Present, sir. Present.
Yes, fine. And team 10, anyone from BJMC Pune? BJMC Pune.
You note down, Rohit, who are absent.
Okay, sure.
If they join, they have to inform us that they have joined.
Team 11 Kilpauk Medical College, Chennai.
Yes, sir.
And team 12 MAMC New Delhi. Anyone from MAMC New Delhi?
Yes, sir. Ma'am,
Present, sir.
present, sir.
And team 13 ESIC Faridabad. Okay. And team 14 SRMC Chennai, Sri Ramchandra Medical College Chennai.
Present, sir. We are there.
There. Team 15 AIMS Bhubaneswar. Anyone from AIMS Bhubaneswar?
Yes, sir. Present.
Okay, Arnab Bandapatiya, fine.
Yes, sir. Yeah.
And team 16 AIMS Rishikesh. Anyone from Rishikesh? And last call, I am for people from AIMS Rishikesh, ESIC Faridabad, and BGMC Pune. Anyone here? Okay, fine. Okay, ma'am. Out of 16.
Today's proceedings, after introducing the panelists, the case presentation will be for 10 minutes and followed by discussion 40 minutes and questions by each team 2 minutes for each team will be given, and later the analysis of the presentation by the panelists. After that, the instrument X-ray, operative session, counseling, documentation. After completing all the sessions, there will be analysis and suggestions by the panelists and questions by the audience and delegates, judges. A team of judges from all over country are observing, and they only insisted the roll call, and every team should be present for all the sessions, and the time frame, everything is given and it will be notified, and the judges also uniformly go through and give the marks. So this is the first time happening along with the online prelims, and finals will be at the time of conference Apsicon 24. Rohit, you can go ahead with the introduction of panelists.
Thank you, ma'am. Now I'd like to welcome our esteemed panelists. First is Dr. P. Ramanan, sir. Sir has completed his MBBS from Chengalpat Medical College and MS from Madurai Medical College and MCH from Stanley Medical College, which is famous for hand and microvascular surgery. Sir joined in CMC, Coimbatore Medical College in 2004 as tutor and escalated his ranks from assistant professor, associate, and became professor and HOD of the department in 2019. Sir has 20 years service in plastic surgery in the Department of Plastic Surgery in Coimbatore Medical College. Thank you, sir. We welcome you to this online Plastiquest session.
And under his
Hi.
guidance, the hand transplant was done in the Coimbatore
And-
Medical College.
And reimplant, madam.
Okay, hand raise.
Now I would like to welcome Dr. Nikhil Panse, sir, Professor of Plastic Surgery at BJMC Pune. Sir is Associate Editor of IJPS and also member of member and curriculum committee member of NBE board, and has over 75 PubMed index publication. Sir is famous for his YouTube videos because I am also used to watch sir videos so much. We welcome you, sir, as a panelist for this online session.
Thank you.
He is very famous for the videos, surgical videos, and we get very clear understanding
Clarity.
of the procedure very well.
Thank you.
Clarity.
Now I'd like to welcome our very own Subodh sir. Sir is professor and head of the Department of Plastic Surgery from Gandhi Medical College, Secunderabad. Sir worked as an executive member, treasurer, and as secretary in APSI and Plastic Surgeons of AP and Telangana. Sir also worked as executive member, general council member, and regional secretary in Telangana Doctors Association, and worked as editor for Association of Medical Educationists and academic senate member of KNR UHS Telangana. We welcome you, sir. Thank you for so much for accepting our request.
Thank
He
you.
is my colleague during MCH, and we both joined as a faculty. He at Gandhi Medical College, Secunderabad, and I joined at Usmania. And we used to conduct various academic programs, interdepartmental and all. Even he is conducted various forums, the quiz, as a quiz master. He's very famous quiz master. Even midterm CME, he conducted the quiz to all the audience. It's an open quiz. Welcome.
Thank
Subodh.
you. Thank you.
Now I would like to welcome Ramesh sir. Sir is professor at Department of Plastic Surgery, Bangalore Medical College, and sir has 19 years of experience in plastic surgery PG teaching, and he's been an examiner for various health universities across the country, and one of the NBE faculty and also the NMC inspector. We welcome you, sir, for this online forum.
Thank you, madam.
Okay, sir. Now I would like
We
introduce-
worked as a co-examiners at various centers for various examinations, and during our PG period also we used to attend the conferences and workshops. Welcome, Dr. Ramesha.
Thank you.
I would like to introduce our PG students. This is Team 4, sir. We have 2 students from Government Stanley Medical College, Chennai. First PG is Mohammed Nisar, and the other one is Dr. K. Pritika. And their case is zone 2 flexor tendon injury, sir. So, Dr. Pritika and Nisar, you have 10 minutes to present your case. So I will stop sharing my screen. You just share your screen and go ahead with your presentation.
Good afternoon, everyone. Sir, am I audible, sir?
Yes.
You are audible.
You're audible.
Yes, sir. I'm going to present a 22-year-old male from Ranipet, who is a right-hand individual and he is a mechanic by occupation. His chief complaints are his inability to bend his left index finger. For the past 4 months. Case history, he is a mechanic. While doing his job in a mechanic shop, while lifting a heavy object, he sustained injury to his left index finger 4 months back. And he was immediately taken to the nearby hospital where a skin suturing was done. And afterwards, suture removal was done after 10 days. Following which he was not advised any kind of physiotherapy or any splintings. Later, patient noted that he can't able to flex his index finger. So his main concern was he was not able to use his left hand for routine daily activities like holding the objects and driving the bicycles or two-wheelers. And there was no history of splinting and there was no history of loss of sensation of the left index finger. The past history, he has no comorbid illness and there was no previous history of any surgeries apart from the skin suturing. And he was a smoker and occasionally consumes alcohol.
The patient was examined after obtaining informed consent, and the patient is the general condition of the patient is fair and his vitals were stable, and the patient was examined in a sitting position in a well lit room with his forearm extended and rested on a table in the sitting position. The examination of the left hand, this is the non-dominant hand of the patient, and he has a single scar of size 2 centimeter, which is in an ulnar oblique direction, is noted in the proximal digital crease of left index finger, and the scar appears to be healthy, and here the index finger at rest was found to be out of cascade. And there are no trophic changes that are seen in the index finger. There is no obvious deformity or deviation that is seen in the index finger, and all the other fingers also appear to be normal on inspection. On palpation, the scar is supple. There is no surrounding warmth or tenderness involved. And coming to the movements, here the patient is able to act. There is active flexion of the proximal interphalangeal joint, and distal interphalangeal joint of the index finger is absent. And however, the active flexion of the metacarpophalangeal joint of the index finger is preserved. Upon the other fingers and thumb, the movements are of normal range, and in the forearm and wrist, the movements are in the normal range. And coming to the passive range of motion, all the joints are supple. With regard to the index finger, all the joints are supple, and full passive range of movement is present in the index finger. The other fingers are also normal. And sensory examination, the sensory examination on both the radial and ulnar side of the index finger was found to be intact, and examination of dorsum of hand and forearm are normal. This is the X-ray of the patient, X-ray of the left hand, AP and oblique view, and here we can see that there are no bony, there is no bone injury as far as the left hand or index finger is concerned. So coming to our diagnosis, this is a case of post-traumatic sequelae of 4 months duration. It is a zone 2 flexor tendon injury involving the left index finger.
So, have you completed your presentation?
No, sir. Can we go to management also, sir?
Proceed. Before management, wish to mention anything about the digital alliance?
Sir?
Digital alliance. Vascular status.
Vascular status, we have not done.
Okay. Proceed.
So we have to do X-ray of the left hand AP and oblique view, sir, which we already have, in which I can able to note any fractures or any foreign bodies, and I will take blood investigation, chest X-ray and ECG for routine anesthesia purpose, and ultrasound of the left index. If I have any doubt in examination findings, I will look for the position or location of the pec tendons, both proximal and distal, sir. So my management is exploration and FDP reconstruction of the left index finger from zone 1 to zone 3 using FDS of the index finger as a graft. And post-operatively, I will do immobilization protocol for this patient in a dorsal slab with the wrist in 20 degrees of flexion and the MCP joints in 70 degrees of flexion. And I will inspect the suture line on 2nd post-operative day, and the suture will be removed on the 10th post-operative day. After 3 weeks, I will remove the POP, and I will apply the dorsal blocking splint, and I will start active flexion exercises within the splint for the next 3 weeks, and also along with it, scar massage with coconut oil application. And after completing the 6 weeks of duration, I will remove splint also, and I will do both passive flexion and extension exercise with applying only at the night splint.
We completed.
Your
or is there-
presentation over?
Yes.
Yes.
ma'am.
They are in time, so panelists can start discussing.
Okay. See, you said it is 4-month-old zone 2 injury,
Yes, sir.
Yes, sir.
and you are planning to restore the FTP function using a tendon
FDS
graft.
as a graph.
Do you want to do it in single stage, or is it
Sir,
that you have a different thought?
Sir, the tendon reconstruction, I have to decide whether it is single stage or multiple 2-stage on exploration. Only after the exploration, while exploring the tendon, I will look for the status of the pulley and the flexor sheaths. If they are intact or if it is not collapsed so much, I will do single stage reconstruction of the flexor FDP of the index finger, sir, using FDS graft.
Okay. If such is it, what do you think are the indications for the staged repair?
Sir,
Uh,
can you repeat your question, sir?
What form the indications for staged repair?
Sir, staged repair will be done in complex injuries, sir, where in case of prolonged duration from time of injury to reconstruction, where we are expecting the pulley system to be collapsed, sir. And also in complex injuries where there has been any soft tissue loss over the index finger, where we have replaced it or resurfaced it with flaps or any other skin, so that we are expecting that the pulley system will not be patent, and we have to do a staged reconstruction.
And also when there is a bony injuries or a nerve injury or digital vessel injuries, we have to plan for the staged reconstructions.
In this case, you said you would decide based on the operative findings, whether you would be doing single stage or stage, the decision you wish to take on table. Is it so? That was what has been mentioned, right? Is there any way that ultrasound helps you to decide beforehand?
Sir, most of the time, clinical examination helps in deciding, sir. Ultrasound is mostly it is observer dependent, and the radiologists who are skilled in this musculoskeletal system can able to identify. Otherwise, this clinical examination findings itself is helpful to locate the distal and proximal cut tendons. For example, in this case, the patient can able to flex the metacarpophalangeal joint of the index finger. So it is unlikely that the tendon is retracted to the palm because the lumbrical will restrain the FDP retractions. So most of the time it will be in zone 3 level.
Okay. Any comment on the status of joints? I perhaps missed that.
Sir, on clinical examination, the passive range of movement is full in all the joints of the index finger, sir.
And there is no stiffness.
There is no stiffness, sir.
Okay, on X-rays, the joints.
And X-ray also, the joint space is adequate and maintained, sir. There are no bony injuries also, sir.
Okay. Can you elucidate on the steps of tendon grafting in this case? How would you go about operative steps?
Operative. So first, we will do this surgery under supraclavicular block with under tourniquet control, sir. And I will make a mid-lateral incision over the non-contact side of the left index finger. Then I will open the incision, and the pedicles will be in the dorsal aspect, only the skin will be on the skin and subcutaneous tissue only will be retracted, sir. And I will look for, I will look for the flexor tendons, distal cut location of the distal cut tendons I will do. And I will extend the incision proximally and I will identify the proximal cut tendons. Then in this case, both FDS and FTP are cut. So I will make a incision over the flexor distal 1/3 forearm, and I will retrieve the FDS of the left index finger, and I will use this as a graph, for which I will soak it. I will preserve it under the saline gauze. Then first I will look out the distal cut end of the FDP index tendon, the location of the tendon, wherever it is, and I will open the pulley of the A4 pulley. I will open or went out. So I will retract the FDP index finger at the zone 1 level. Then I will first do the distal juncture tendon repair using, as this is a FDS tendon, the size, there won't be much size mismatch. So I will co-opt the distal juncture using 3-0 proline 2 strand, following which continuous suture using 5-0 proline. Then I will tunnel the graft over the A4 pulley, A2 pulley, and I will do tension adjustment at the level of zone 3 level, and I will co-opt the proximal juncture using 2-0 proline, 3-0 proline, modified Kessler-Mason-Allen suture, follow it which continuous suture using 5-0 proline. In this step, the distal cut end of FDS tendon, I will fix this distal stump over the volar plate or the soft tissue around the middle phalanx, so the middle phalanx. Then I will
proceed.
Then I will, sir.
Proceed, try completing further.
Yes, sir. Then I will do skin suturing using 4-0 nylon, and I will do dressings, and I will apply the dorsal hand POP with wrist in 20 degree of flexion and metacarpophalangeal joints in 70 degrees of flexions.
What would be the advice later, further on? You have splintered, agreed. Later on, how would you proceed?
Sir, we will immobilize the hand in a dorsal slab and advise the patient to do hand elevation. And following which we are going to follow immobilization protocol, sir. So the suture line will be seen on the second post-operative day, and the suture removal will be done on the 10th post-operative day, sir. And following which the POP will be retained for a period of 3 weeks. And after 3 weeks, the POP will be discarded and patient will be changed to a dorsal blocking splint, again with the wrist in 20 degree and metacarpophalangeal joint at 70 degree flexion. And patient will be advised to do scar massage, and patient will be started on active flexion exercises within the dorsal blocking splint for a period of 3 weeks. And after the end of 6 weeks, we will start the patient on passive mobilization of all the joints, passive flexion extension exercises, and with usage of night splint for 3 weeks.
You said zone 2.
Yes,
if zone 2 repair, you will start mobilization after 3 weeks only. When will you start mobilizing a zone 2?
This is a zone, it is not a repair. We have done a reconstruction using graft, where there are 2 suture lines distally, proximally, along with a non-vascular graft also. So we don't mobilize the patient earlier.
So you have examined the patient. You
Yes, sir.
talked about examination of the FDS. How do you examine a FDS without touching the patient? How can you examine a FDS without touching the patient? Just on inspection without touching the patient. Is there any way of testing the FDS? Are you aware of? Yes, no?
No, sir.
You ask the patient to do like this. If this is possible, FDS is intact. Otherwise, patients do like this, O sign, typical. You didn't mention about 2-point discrimination. How do you test for 2-point discrimination? It is likely that the patient might have, you just mentioned about sensations, right?
Yes, sir.
How do you test for 2PD?
It is two types of static and dynamic 2-point discriminations.
Okay, but how do you test? Basics. Okay, now let us imagine that this patient came to you just immediately after injury. How does mode of injury decide where the likely position of the tendon would be intra-op?
Sir, we have to see how the injury has happened, sir. If the injury has happened in when the fingers were in a flexed position, then it is likely that the distal tendon will be retracted farther than the site of injury, sir. As in this patient, he was holding a heavy object, he demonstrated that he was holding it in a flexed position, like a cupped position, so that we are expecting the distal end to be retracted further, sir. When if it is in a straight position that the injury has happened, then the tendons are likely to lie at the level of injury itself.
So 2 questions subsequent to this. Patient has come to you immediately after injury. How would you manage this? And what would be your principles of hand incisions which you would apply during exploration or during repair?
Sorry, patient comes in emergency, we try to I will try to repair both. I will look for the cut of injury of FDS and FTP. So I will look for it. Then I will make mid-lateral incision, sir. Because
can you tell us on both sides, how does doing FDP alone and doing FDS and FDP, what would make, how would you make your choices? What would be the conditions doing FDP alone or FDS and FDP both?
Sir, I prefer to repair only FDP of the injured fingers.
Why is that? Patient appears to be young, functional, needs strength in the grip. Why only FDP? Why not FDS and FDP both? Acute injury.
Sir, if I repair both FTS and FDP, there might be a bulkiness in the suture line within this flexor sheath, sir, which hinders the gliding of the both FDS and FDP tendons. So if I repair only FDP tendon, if it will favor the gliding, sir. But repairing or else I can able to repair only the one slip of FDS, so that proximal interphalangeal joint movement will be preserved, and it also favors gliding of the FDP tendon also. And moreover, if I repair FDS, this vincular system will be intact, so that the blood circulation to the FDP also will retain. But I won't do, because it will hinder the FDP gliding. So on the cause stiffness, so I will repair only FDP.
What are the principles of hand incisions? General principles. You are focusing only on mid-lateral incision. What other options do you have, and how do you make that choice?
I can able to do Brenner's incision, mid-lateral and mid-axial incision, sir. While making Brenner's incision, I will make a flap over the volar aspect, so it will be retracted. So there will be suture line in the volar aspect, sir, where it will be placed on the pulley system or fibrous flexor sheet. But if I make a mid-lateral or mid-axial incision, the entire skin flap will be intact, so that suture line will be on the lateral side, and the scar won't be at the volar aspects. So the pulley system will be, the gliding forces of the pulley system will be maintained if I make mid-lateral incisions.
So this zone 2 is classically called no man's land, isn't it?
Yes, sir.
Why is it so?
Sir, it was thought that because it is a tight osteofibrous compartment, whatever tendon repair, once there was an injury there and tendon repair that was done, the results were not very good at the initial time. So Banal advised that he advised that tendon repair should not be done in the zone 2 in the initial stages, sir. And you always suture and wait and do a reconstruction is what it was advised initially, sir.
Sir, please.
Can you name the person who has attempted repair of both, despite Banal mentioning it as no man's land?
Who was the one to present a paper in the American Society about the repair, zone 2 repair?
Don't know, sir.
Don't know. Imagine.
Kleiner.
Imagine.
Kleiner.
Okay.
Right. Now imagine there is no distal stump of FDP. How would you address the issue?
Sir, we can use bone anchoring sutures, sir. And if bone anchoring sutures are not available, then we can use the help of Keith needle or a K-wire to drill through the TPX bone. And it is fixed in the dorsal nail plate, and over a button it can be fixed, sir.
Now you said you would go for a staged reconstruction if the underlying structures intra findings are not very favorable, right?
Yes, sir.
If you explore the wound, you find that all your pulleys are fibrosed. There is probably no pulley structure. You would go for a first stage reconstruction, right? How
Yes,
would
sir.
you go ahead with that?
Sir, I have a question, sir.
How would you go about
First
doing
stage
Yes, sir.
tendon reconstruction.
Sir, I will do a modified Paniva Holwich technique for this patient, sir. Where? Yes, sir. It is modified by the modification. It's actually a modification, sir, where on exploration there will be a fibrosed pulleys. So we used Hunter's rods, a silicon rod, to be placed in the pulley in the actual flexor sheet, sir. That distal end of the silicon rod is sutured to the zone 1 level, sir. And this proximal end is left as such. Then I will identify the proximal cut ends of the FDP and FDS. And in the first stage, I will repair the proximal cut ends of the FTP and FDS using the 3-0 prolines. Then I will suture and I will immobilize the patient, and I will by dorsal hand POP. Then I will start doing active flexion exercise of the fingers after 10 days. Then
how can you do active flexion exercises? You haven't sutured the proximal end.
Passive flexion exercise of the fingers after 10 days suture removals within the
why
skin.
didn't you suture the proximal end? You can start with active flexion exercises, isn't it? You sutured only the distal end. Why not proximal as well?
So the rod is fixed, the silicone rod is fixed at the distal end, but proximal end.
Why? That is what I'm asking. Why?
Otherwise, it will migrate to the migrate proximally, sir.
No, you're not getting my question. What happens if both proximal and distal ends are sutured? If you use a tendon graft,
yes,
I'm not talking of a tendon rod or a silicone rod. You are going to suture proximally as well as distally.
Yes, sir.
Isn't it? Why not do it with a tendon rod? What happens?
Sir, it will cause buckling of the silicone rods, sir.
What is the reason for that?
Sir, the silicone
what is
rod
the-
is a fixed length. It will not, there is no
Yes.
excursion in the silicone rod, sir.
Right. Okay.
So when there is an exertion, what is the advantage? The pulleys are well developed. When you start moving the silicon rod, the pulleys are well developed, so that in the next stage of reconstruction, it is very good, easy.
Yes.
Yes, sir.
When would you go ahead
What
with the
are the-
next stage?
The next stage will
What
be
are-
done after this wound healing process completed, probably after 3 months of the first stage, sir.
What are the tendon grafts you can use
The
for
tendon graft
reconstruction?
for
Hmm.
reconstruction.
secondary
In this case, FDS is also injured, sir. So I will use FDS as a graft for this case. If it, otherwise, the other tendon grafts I can use is palmaris longus graft, plantaris graft, and I will use long extensor tendons, toe, and also flexor of the toe grafts. But in this case, I will do FDS tendon as a grafts.
Okay. So in a secondary reconstruction, it is better to repair only one tendon. Only in acute cases, we go for both tendons. So you can sacrifice the FDS tendon.
How do you assess the outcomes in these patients?
Sir, we usually assess, the assessment is done at the end of 3 months, sir. And we usually assess using the Strickland criteria. And we measure the total active motion of both the proximal and distal interphalangeal joint of the index finger, sir. And if it is more than 150 degrees, then it is excellent. And 125 to 149, it is good. And 80 to 120, it is a fair result. And less than 80, it is a poor result.
So you're talking of only excursion. What about the strength? How do you assess the strength? You're talking only of excursion, isn't it?
Yes, sir. Yes, sir.
What about the strength? You also need to have strength. If there is no strength and only excursion, it doesn't serve the purpose, right?
Yes.
How do you assess the strength part of it? Have you heard of some dynamometers?
Yes.
What is that? Do you know the name?
Dynamometer.
Starting from J.
Dynamometer.
Yeah.
It is dynamometer to assess the strength of the. It will measure the strength of the grip strength. It will measure, sir. This dynamometer.
Yes. The name.
Name of the.
It can be also used to assess individual pinch strength, not only grip strength. There are certain modifications which can be used to assess individual pinch strength as well. Okay. What functional problems does this patient have?
Before repair or reconstruction?
Before repair.
He can't able to flex his proximal and distal interphalangeal joints, sir, so that it hinders the activities of other 3 fingers. Like while if he wants to ride a 2-wheeler, he can't able to hold the accelerator or brake because this index finger is hindrance to the brake and the handle. So this is the main concern for him.
Is tendon transfer an option for this patient?
No, sir. If at all the flexor tendon of thumb is injured, we can do tendon transfer. Here we already have a donor tendon and the intact tendon is there. So there is no need of tendon transfer for this patient. We will do tendon reconstruction for this patient.
Fine. Shall we have this continuing or do we proceed to another?
10 more minutes are there, so you can continue the different aspects.
Okay.
Okay, if the
Examination, anything you can ask related to flexor tendon,
So
repair and reconstruction.
okay, after a repair, see the forearm muscles are in a disused state, no? There is a mild atrophy. How will you provide strength to the forearm muscle?
Sorry, I can't understand the questions.
See, 4 months he has not been using the finger, no?
Yes, sir.
And he will not be having his full grip strength, isn't it?
Yes.
How will you strengthen a forearm muscle? Then only he will get the dynamic strength, no? Original dynamic strength. For that, you have to do some physiotherapy alone may not be sufficient. What else can you give extra? You can go for some mild electrical stimulation to strengthen the forearm muscle so that it can gain the original strength. That's also possible.
Okay, sir.
Okay, sir.
coming to examination of the patient again, clinical
Yes.
examination. Initially, I asked you, how do you assess the function of FDP without touching the patient? How can you assess the sensations of a patient without touching the patient? Can you assess? Now, it is very likely that this patient might have lost his sensations. In your examination, it was found that he had sensations, but let us assume, without touching the patient, just by inspection, can you assess sensations in a patient?
If any trophic ulcer present over the finger, it can.
Okay, that is a pointer that sensations are lost. Anything else? If the patient is a baby, 6 months year old, patient is not going to tell you verbally. In those cases, how do you assess? You want any clues? You dip the hand in water, dip the finger in water, what happens?
They will withdraw.
No,
be
I'm
color
not talking
change,
of
sir.
hot water. How can you put it in hot water? Insensate
sir.
finger.
Because of autonomous activity, there will be a vasodilatation and constriction, so that hyperemia of the skin will be there.
If we dip our own hand or finger in water for 10-15 minutes, what is there? What do we see?
Sodden.
Wrinkling is seen. That doesn't happen in insensate hands. It happens only because there is autonomic activity which is present. Where there is dysfunction, you don't get wrinkles. That is one thing. What do you see on inspection? In sensate hands, there is a bit of dirt if you see properly. Insensate fingers are very shiny because there is no moisture in those fingers. As there is no moisture, there is no mud or dirt or dust which is retained anywhere, be it hand, be it limbs. So insensate limbs are exceptionally clean and smooth. They don't have those micro dirt particles which are there. So that is how you can assess sensations in patients who are mentally retarded, in kids, or patients who are uncooperative and who don't usually respond to your communications. Okay, you guys are from Stanley, right?
Yes, sir.
Yes, sir.
So what can you tell us about the red line?
Sir, the red line is not there currently, sir.
Yeah, I know. But for those of us who don't know about the red line, there are
red
many
line
residents
was
among the audience. They don't
red-
know about the concept of red line. You should elaborate it for them.
So the red line was proposed and implemented by Professor R. Venkateswamy, sir, who was the director at that time in Institute for Research and Rehabilitation of Hand. So that is a line of red paint will be there on the wall that will start from the trauma initial emergency department up to the plastic surgery hand emergency, and that line will run through the entire hospital wall, so that any patient who has a hand injury need not search anywhere, and if he follows the red line, he will come to the Stanley Hand Emergency Department.
Right. So it was a very disruptive and fantastic thought at that point of time, which promoted hand surgery enormously.
Okay, well, see, there is suddenly an elderly person complains of inability to flex the index finger or thumb. What will you suspect?
Without trauma, patient is unable.
Yeah, no history of trauma at present. What are the things you will elicit in the history
There may be a chance of
for elderly person?
closed tendon rupture is possible in elderly patients.
Okay, causes? Any operative history you will ask specifically if you say there is a rupture? Distal radius plating is one of the cause for tendon rupture. It's one of the complications of flexor tendon rupture. But maybe if you trace the history, he will say. Do you know, can you list out the protocols of physiotherapy after zone 2 flexor in tendon repair? Immediate. Can you? What are the protocols you will follow?
Sorry. In our institute, we follow immobilization protocols. There are other protocols like passive mobilization, early passive mobilization protocol, active mobilization.
Name of the protocols.
The passive mobilization protocols is Kleinert, modified Kleinert protocol, Duran-Hauser protocols. These are all further modified by the Strickland and Jetil to form a Indianapolis method. These are all passive mobilization protocols. Then there is a combined active and passive mobilization protocols like Nantong regimen. Then
what do you follow? You don't follow Kleiner traction in Stanley, yeah? Nowadays
we follow immobilization protocols. We are not following Kleinert protocol.
Why?
Sir, it depends upon the patient and it depends upon the literacy of the patient also, sir. Because they have to understand the surgery and the nature of injury also.
So even if an educated patient, you will change the protocol, is it not?
Sir, in educated, sir, yes, sir. In educated person, we can change the protocol. Moreover, it depends upon the surgery also, sir. Because to follow the mobilization protocols, we have to use 4-strand repair, sir. What we use is 2-strand repair only. So we are not doing mobilization.
I'm not bothered about the repair. I'm bothered with the protocol. So explain one protocol. What is low force, low excursion? What is low force, high excursion? Okay. See, in Kleiner, there is a low force, but and there is low excursion. See, the patient passively, there is active extension and there is passive flexion.
Yes, sir.
So one is active, one is passive. In endurance, you both are low, very low. You use the other hand to flex the fingers and extend the fingers. That is endurance. And another one is you extend the wrist and flex the wrist. Yes, automatically, the tendons will glide. The flexor tendon, repaired tendons will. So these are all various protocols for which you have a good range of motion when you start practicing. and you should start client protocol at the earliest. But what is the complication of the client protocol?
There will be a stiffness of the proximal interphalangeal joint.
That's mild flexion contraction of the PAP joint, because the PAP joint is kept at 60 degrees flexion always. So you have to relax it at the night. You should release the flexion, the rubber bands, and then make it in full extension. And then when you start doing exercise, you should start again, once again, apply the rubber bands and start doing it. In that way, you can prevent flexion contraction.
Yes.
Yes.
Can we move to the next session, sir?
And can I ask a question?
Yes, sir.
Hello.
Yes, sir. Yes, sir.
So Mohammed and Preeti,
Yes, sir.
very welcome to you for presentations. You are a very lucid presentation. I have a question. How do you stitch and how do you stitch the tendon graft? Which one you do, distally or proximally first?
First, I
If you
will
do it, why?
First, I will do distal juncture, sir, because
Yes.
it will helpful in tension adjustment.
So how quantitatively you assess the tension? Quantitatively, not qualitatively.
I will compare with the other fingers. Flexion
So
of,
what you see about the other fingers?
yes, sir.
Cascade.
Cascades, sir. Other fingers.
How do you quantitatively know about how much of tension? Do you have any quantitative method in India anybody has devised? Where Dr. Panse comes from? You know it or not? Yes or no?
No, sir.
I will give you a hint what sir has asked. Is it
And
is specifically used for tendon transfers in leprosy. It was specifically used for tendon transfers in leprosy.
just Srinivasan.
No,
No.
the person who described it was an orthopedician. He has fixators named after him. So I think these are big enough clues.
No, sir.
B.B. Joshi.
Sir?
Dr. B.B. Joshi.
Josh. Okay.
Joshi.
Joshi.
Okay. This my second question is how do you reconstruct the pulleys if you need to have it? How do you reconstruct the pulley?
There are various methods of reconstruction of pulleys. One is I will use the this Palmaris longus graft or FDS graft and wind around the middle phalanx and proximal phalanx to reconstruct A2 pulley or A4 pulley. Or if there is any remnant of pulleys are present, I will make a weaving over the remnants. Otherwise, I will take extensor retinaculum also to reconstruct this pulleys.
Good. How do you what is check ren deformity? Why it occurs? You leave the distal part of the superficialis tendon a little.
Yes,
you don't cut it from the distal.
It will cause swan neck deformity, sir, because of hyperextension at the proximal interphalangeal joints. I will stack that distal stump to the volar plate of PAPG or soft tissue around it so that this swan neck deformity is prevented.
Okay, very good. What is stereognosis? We talked about so much about sensations, 2-point discrimination. What is stereognosis?
Stereognosis is the recognition of the objects or the joints in the space while touching.
So the three dimensions you can make out with hand.
Yes, sir.
What type of coin it is, how much is the coin, is it 1 rupee or 5 rupee or 10 rupees? So
Yes,
depends on that. That is the stereognosis. That is one of the tests to know the functions of the hand. Okay.
Yes.
I hand over, please. Thank you so much.
Hello.
Do we proceed to the next part or do we continue, ma'am?
Did they cover the how they will assess how much is the graft required, length required for reconstruction of the tendon?
Ma'am, the graft requirement is from zone 1 to zone 3 level. I will do reconstruction. So for that, the FDS graft is adequate. While doing tension adjustment, that only will decide the required length of the FDP reconstruction graft. So there is no exact measurement of graft length.
So what
What
type
is
of
risk?
repair you will do in distal part and the proximal part, proximal end, and which wound you will close first, and how will you adjust the tension?
First, I will do the distal juncture. I will close the skin closure over the distal.
Repair, what will you do in distal end? And how will you do in the proximal end? Is there any difference you follow or the
Nothing
what
different.
type of suturing?
Ma'am, we will do end-to-end modified Kessler-Mason-Allen suture for both distal and proximal. If we use FDS as a graft, otherwise, if we use Palmaris longus as a graft, I will do Pulvertoff technique.
What both?
No, proximally.
Proximal. So where will you keep your suture line of proximal end?
In zone 3 level, ma'am, in the palm.
Okay. And after repair, how will you test the gliding? Will you check it?
Yes, ma'am, we will check. One is by passing, extending the finger so that the gliding is present or not, it's adequate. Other one is tenodesis effect of the wrist. While extending the wrist, there will be a passive flexion of the fingers. So by tenodesis effect, I will check the tension of the reconstructed index finger.
Yes. Well, how do you check the presence or absence of Palmaris longus? You demonstrate on your colleague.
Ma'am, I will oppose the thumb and little finger, and I will flex the wrist against the resistance. So I can able to palpate the Palmaris longus. This is Schoffer's test.
So in how much percentage it will be absent?
It will be present in 80 to 85%. 15 to 20% it will be absent.
Is it bilaterally it will be absent or unilateral?
Bilaterally it will be absent.
So if you test one hand, there is no need to test for the other hand?
I will check, ma'am. We have to test both the hands.
Yeah. May not be bilateral absent. Okay. Then
Madam, your video is not available. Your video.
Okay. Now the interesting session of the thing. Other teams will put questions to the presenting team. Rohit, announce the team members.
Team 1, Madras Medical College, ma'am.
2 minutes for each team.
Good evening, ma'am.
Yeah.
What is quadriga? In which fingers can we?
You are breaking.
What is
quadriga effect?
Quadriga effect. And in which fingers we test?
Whenever there is more tension in the repair or reconstruction, it will cause a laxity of remaining flexor tendons. So the flexion will be hindered to the remaining tendons. This is called a quadriga effect.
Why does this happen?
Because mid-ring little finger has a common bellies of the flexor tendons, FDP tendons. So if we repair the, like for example, if I repair the FDP of the ring finger with more tension, it will pull the tendons distally. So there won't be adequate tension while contraction of the flexor tendons of the remaining mid finger and little finger also. So there will be laxity of the weak flexion over the remaining fingers. This is called a quadrija, and this is the mechanism.
Yes, ma'am. Thank you, ma'am.
Second team.
Good evening, team Jipmer. Can you describe the volar plate anatomy and classification of volar plate injury?
Volar plate anatomy, it has two parts. One is proximal and distal. Proximal part is it is fibrous, and distal part is fibrous, and the proximal part is membranous. And this volar plate alignment will be different in metacarpophalangeal joint and proximal interphalangeal joint. For example, it will be lax and extend in metacarpophalangeal joint. There is a slight
You
degree of
describe
extension.
the PAP joint alone. What is the region attachment? Anterior, posterior, lateral attachments. Volar plate anatomy.
Volar plate is attached to the proximal interphalangeal joint volar plate. It is attached to the base of the middle phalanx and the condyles of the proximal phalanx, and there is a proximal extension called Chekrin ligament. It is a membranous part. Laterally. And collateral ligaments are attached to the volar plate. That is accessory collateral ligament and proper collateral. Proper collateral is like from bone to bone, and this accessory collateral ligament is from this main bone to volar plate.
What is the classification name? Injury classification?
That we don't know.
Okay. It's a year-turn classification.
Okay.
Thank you.
Next, team 3, madam, KGMC Lucknow.
Hello, good evening, ma'am.
Yeah.
Team KGMU. My question is, among FDS and FDP, which tendon should be repaired first and why?
Which tendon is repaired means in acute injuries. In acute injuries, I will repair the flexor digitorum profundus.
Okay.
Then, sir, hello?
Yes.
So you are asking in zone 2 level. Or which level, sir? Because it depends on the level of the injury, the flexor anatomy is different.
Okay, in which level you will repair the
because
FDS first?
if the injury occurs at zone 3 level, FDS will be the superficial tendon. If it is I will repair the FDP first and FDS second. If it is occurs at zone 2 level, FDP is superficial. So I will repair FDS and then later I will do FDP. So it depends upon the zone of injury.
Okay. Why FDS first you will repair?
FDS is the deepermost structure in the zone 2 level. If at all I have to repair, I will repair the FDS first, then I will repair FDP. Most often we will repair only FDP alone in zone 2. I won't repair FDS. Because it will cause the flexion of both distal and proximal interphalangeal joint. Only thing is the grip strength of the proximal interphalangeal joint only will be decreased while repairing the single tendon.
Okay. Also, FDS is also repaired first because it will also protect the vingulum longum to FDP also, and it will provide the gliding interface between the FDP and underlying.
Yes.
Okay. Thank you.
Next, ma'am, team 4 from
Team 4 is
team 5, AIMS New Delhi.
Good evening, ma'am. This is from AIMS New Delhi. And my question is, when you do a flexor tendon reconstruction, what are the prerequisites for the flexor tendon reconstruction? What are the things you check before tendon reconstruction?
We check that the scar should be supple, and if we are going for reconstruction, then adequate time has to be there from repair to reconstruction time, so that the inflammatory phase has settled down. The scar should be supple, and more importantly, the joint range of motion should be, passive range of motion should be full, and all the joints should be supple before we embark on reconstruction.
Any classification for that?
There is a boys classification to grade the this.
Yes, okay, thank you.
Team 6.
Good evening, ma'am, from Bangalore Medical College. What is intrinsic and extrinsic muscle tightness?
Intrinsic muscle tightness and extrinsic muscle tightness.
Yes.
So
And how do
intrinsic
you test
muscle,
it?
I hope you are asking about the lumbricals.
Yeah.
So if we use a long tendon graft, the lumbricals will be migrated more proximally. So instead of flexion, there will be a hyperextension in instead of flexion, it will cause an extension of the PAP and DAP joints. So this is a lumbricus flex finger you're asking.
The test is evaluated by Banner's test, where we evaluate the presence of intrinsic and extrinsic muscle tightness by comparing the range of motion and force needed to passively flex the PIP joint, while the MCP joints are passively extended and flexed. In extrinsic tendon tightness, passive flexion of the PIP joint is reduced when flexing the MCP than when extending the MCP. And in intrinsic tightness, passive flexion of the PIPJ is less when MCP is extended than when MCP is flexed. Thank you.
Okay, but team 7, CMC Vellore.
Dr. Bala from CMC Vellore. What are the donor sites of the tendon graft?
We will, since if the FDS is already injured, we can use the FDS tendon of the same finger. Otherwise, we can use the palmaris longus from the same hand. It will be in the same and under same anesthesia. Otherwise, we can go for plantaris graft or from the long extensors of the toes.
Yeah, thank you.
Next team.
Come on. Team 8, Sattajan Hospital, New Delhi.
Good evening. Hello.
Yeah.
Yeah. I would like to ask, what are the methods to prevent adhesion formation during tendon repair?
Sorry, voice is not clear, sir.
How will you
What are the-
avoid adhesions?
What are the methods to prevent adhesions during tendon repair?
For tendon repair or
While tendon
Sir,
repair.
we will. Hello.
Do you have any? Hello.
Yeah. So we should minimize the incisions required for tendon exposure, and then we will use an atraumatic technique for repairing the tendons. And it is preferable to do a 4-strand or a 4-strand repair or a 6-strand repair, so that early mobilization can be started. And also use of epitendinous sutures can be used so that adhesions and raw areas there are no raw areas that are exposed that can prevent adhesion formation. And if we are doing a 4-strand or 6-strand repair, we can start an early mobilization protocol, which will prevent adhesion formation.
No, I'm talking about intra-op methods. Any drugs can you use? Any agents?
Any drugs we can
Intra-op
use,
and post-op also.
any drugs which is used to prevent adhesions, like like corticosteroids, 5-fluorouracil, we can try, sir, and hyaluronidase, but they are not much of useful in trials.
Okay.
Only these active motion protocols helps in preventing adhesions.
Yes. They will also weaken the repair post-op also. Thank you.
Corticosteroids, hyaluronidase, and 5-fluorouracil are the drugs which can be used to prevent adhesions.
Okay, thank you.
Now team 9 from RML.
Good afternoon. So the question is, you mentioned that you would do a stage repair in case of damage to the pulley system. So can you just quantify the injury to the pulley system? Like, when do you say that it is an inadequate pulley system?
The adequate pulley which is needed, the important pulleys which are needed are A2 pulley and A4 pulley. So we can vent out these pulleys like the length of the A2 pulley is like more than 2 centimeters. So we can leave at least 5 mm of the pulley. That is the minimum amount of the length of the pulley which is required for the adequate flexion. So we have to leave at least 5 mm of the pulleys.
No, my question was what extent of injury to the pulley system is termed as inadequate? That means you will have to go for a stage reconstruction.
The minimal requirement is to have at least A2 and A4 pulleys that need to be intact. And even if that is not there, then we will go for pulley reconstruction.
Right. So actually the answer is when there is injury to the A2 pulley to the extent of around 25% or 75% of the A4 or 25% of both A2 and A4, that's when we have to go for a stage repair.
That's what
It is
we
more of
said.
a clinical judgment than.
That's what we said. Only at least 5 millimeter. That is 25%.
Yeah, that was about A2. So even A4
Yeah.
up to 75% of A4 or a combined of 25%.
Fine. Yes.
Yeah.
Can we move to team 10? BJMC Pune. PG is from BJMC Pune. If they are not available, we move to team 11 from Kilpauk Medical College, Chennai.
Good evening, everyone. I would like to ask, in the immobilization protocol, after the early stage, after 3 weeks, during the mobilizing, what are the different fist positions which are done, which will enable the gliding of FDS and FDP tendons?
There are few positions like hook positions, duck positions, and the rolling of fingers over the other fingers.
So which position will
These are the tendon gliding exercises.
Yes. So which fist position will enable the maximal differential gliding?
Yes. Hook
So
position.
hook. Yes, correct. Yeah. Hook fist. Yeah.
Yes.
Okay, we move to team 12, Mamsi from New Delhi. PG is from Mamsi, New Delhi.
Hello.
Yeah,
Hello.
go ahead.
Yes.
Clinate physiotherapy and modified Clinate protocol. What is the major difference of modified from the original Clinate?
In the original Clinate, the metacarpal bar was placed more in the forearm, and later it was modified to be placed in the palm itself at the level of metacarpals to enable more flexion of the proximal interphalangeal joint also.
No, the main modification from the original Clinate regarding to the rubber band traction. Main difference from the original to modified.
Initially, it was needle was passed and the rubber band was passed over the nail plate. Later, it was modified.
No, is it related to prevention of contracture at PIP?
Contracture,
Regarding contracture,
APJ.
So we remove in the night time. We remove this proximal band.
So the rubber band traction is straight line in original Clinate. In order to make the PIP to pull, we make a directed traction palmar pulley in modified Clinate protocol. So it prevents the PIP contraction. That direct traction through the palmar pulley is the modified Clinate.
I think, ma'am.
Hello. That's
Lakshmi ma'am.
Next question.
Panelists.
Subodh sir.
I just
they answered the same, I think.
No,
Yeah,
there should be some clarity about this. Panelists can enlighten this point.
No, what she answered in the first, the bar there is moving ahead. So that was the answer. She described in a different way. They answered properly in the beginning. So he's pushing the bar palmar from the forearm to palm.
Yes, so I felt the same, sir.
Yes.
Now team 13, yes, I see Faridabad. Now team 14, SRMC Chennai. PG
Yeah,
from
what are the subdivisions of zone 2 and after whom it was named?
Subdivisions of zone 2 is divided by 4 by the tang. Zone 1. Zone 2A is the insertion of the flexor digitorum superficialis tendon, and zone 2B is between this insertion and the distal margin of A2 pulley. Zone 2C is beneath the A4 pulley, A2 pulley, and zone 2D is proximal to the.
Yeah.
Madam, PG is not responding. PG from SRMC Chennai is the
Yeah,
answer.
sir, sure, sir. Is that the correct answer, sir?
Okay, sure.
Over, all teams are over.
No, ma'am, we have 2 more teams. One is from AIMS Bhubaneswar, team 15.
Good afternoon, ma'am. My question is, can you please briefly enumerate the different modes of blood supply to a flexor tendon?
There are for the flexor tendon, there are 2 types of flexor. Actually, there are 2 types of tendons. One is intrasynovial and extrasynovial tendons. So consider this flexor tendons. It is intrasynovial tendons. So it has 2 types of blood supply. One is through this vincular system, vinculus longus and brevis, present in the FDS and FDP. And another one is through the synovial diffusion, which is present in the as it is present in the flexor sheath. This intrasynovial tendons, on the volar aspect, there are small pores will be present. So while flexion and extension, there will be a diffusion of synovial fluid through this pores into the flexor tendons. And this so this proximally this volar aspect, it is an avascular structure because the vinculum longus and brevis are present more on the dorsal aspect.
Yeah, okay, great. So the second.
Go on.
No, you can complete your answer.
No, go on.
Yeah, so the second option which was told was correct. For the first one, along with the vincular system that arises from the paired digital arteries, longum and brevis, as mentioned, the tendons also
There are
receive
also the
contribution.
osteotendinous junction and the myotendinous junction,
Yes.
also third and fourth.
Osteocutaneous.
And
It's not exactly
myotendinous
osteocutaneous.
junctions.
It is the junction where the tendons come in contact with the bone that is at their insertions, as well as there is partly contribution from the dorsal vessels as well.
Yes.
You answered correctly. Great.
Thank
you.
Now team 16, names Rishikesh.
Hello, good evening. My question is, what is post-operative TAM score?
That is the total active motion with which we assess the total flexion at the proximal interphalangeal joint and distal interphalangeal joint of each finger, and it is added together, and that is what is the Strickland criteria is based on.
Yes, you are right. Can you describe the formula? Like how it is made?
We forgot, sorry. That is, it's like adding DAPJ, PAPJ, and by subtracting the other flexion. Sorry.
What is
Yeah, partially you are correct. It's MCP plus PIP plus DIP flexion minus extension length.
Yes.
Thank you.
All teams are completed.
Right now, 2 teams haven't attended the session, ma'am. Team 10 and team 13. One is BGMC Pune and ESIC Faridabad.
Okay. Any questions from audience, other faculty, PGs who are attending this session? Any chat box questions?
No, ma'am. Till now, no questions.
Okay, to the presenters, I am asking one more question. You told so many methods of assessing the function of the flexor tendons. What is the clinical method? Simple clinical method. You grade excellent, good, average, poor function. Nisha? How will you assess clinically the function of the flexor tendon after your repair? Clinically, you see the movement. Can you tell how you will assess? One clue I'll give. Okay.
Okay.
It is the relationship of the tip of the finger to what?
Tip to palm.
Yeah.
To palm, tip to
Not a palm. Palm is a very big structure, isn't
tip
it?
to distal crease, tip to PAPJ. That is how we clinically.
The distance between the tip of the finger to the distal palmar crease. If it is touching that, it is excellent. And remaining grading unit, right?
Yes.
Anyway, who got the Padma Shri award from Stanley?
Professor Venkataswamy, sir.
His full name?
Professor R. Venkataswamy.
Which year?
He started in 1970.
No. Which year he got Padma Shri? Padma award in which year he got?
Recently he got, sir. We don't know.
No, the recently has no meaning. Plastic surgeons are very focused and they should speak specific. Anyway, who are the lady plastic surgeon got Padma Shri from Chennai? Madam is lady, no? So I want a lady to get a Padma Shri. Who got it?
She is from, she was a HOD of CMC Vellore, sir.
No. Yes. But I am asking from Chennai. You are right.
Matanki Ramakrishnan, madam.
Full name?
Matanki Ramakrishnan.
K. Matangi Ramakrishnan.
Ramakrishnan from Kilpok.
Yeah. I think I asked a little general question, but it makes a difference because your predecessors have done a lot of hard work to get that institution to Institute of Hand Surgery. Okay. And that Pansay was talking about. You know Arcot word? Faridi Arcot word? In Stanley, you know there is a Arcot word.
Arcot word. Yes,
The
sir.
word name is Arcot word. You know that?
Yes, sir.
So I think these are things to be known because you belong to that great institute. Okay. Thank you so much.
Thank you.
So now we'll go to the next session. Shall we? Yeah.
Yes, ma'am.
Go ahead.
Get my screen.
Ten minutes time. Tell the diagnosis and
Post-traumatic, probably a post-traumatic raw area of the left leg in the middle third region, in the middle third of leg in the anteromedial region with exposed implant.
tell your management also so that the panelists will ask you questions.
Ma'am, there is an exposed implant, so we have to give a soft tissue cover. So I will plan, as this defect is in the middle 1/3 of the leg, I will look for the, first of all, I will look for the X-ray of this left leg to assess the status of the bony fixation. And for this, I will do hemisoleus, medial hemisoleus flap cover. And I will apply SSG over this muscle flap.
Do you wish to do this flap with the implant in place or? You wish that it be removed beforehand.
Did you get the question?
Yes, ma'am.
Yeah.
Yes, ma'am. Sir, with the implant in place, I would like to give a vascularized tissue. That is why I am planning for a muscle flap to be given over this defect. And also they have fixed with a plate and screw. So I am thinking that they will not require a further procedure for fixation, and approach may not be required. So I will go for a muscle flap with SSG. Sir.
His hemisoleus is a very well vascularized muscle flap.
Soleus muscle, it's a vascularized, it's a well vascularized.
How are you basing? Is it being based distally or proximally?
Proximally based hemisoleus muscle.
Do you think it will reach this defect?
Distally.
Is it exactly in the middle of the leg or the junction between lower and
It lies junction of between the middle third and distal third. So
can you think of any other option?
or I will do transposition flap from the posterior aspect of the leg to cover this wound. So it would also have a durable skin cover.
Do you wish to base it on a vessel or random? Would it be random?
Random pattern, or if at all it is I will
Posterior
place a posterior tibial artery perforator plus transposition flap.
Because if you are to do it as a random transposition, do you think you will have sufficient girth for it to be based as random transposition flap?
Sir, I will do random pattern transposition flap for this patient, inferiorly based, but I can able to include this posterior tibial artery perforator at the base of the flap.
How can you say that it would be random and still you want to include the posterior base?
Perforator plus transposition flap.
Instead, you say interpolation flap. But still, what would you do? Would you wish to give the flap curve with the implant in place or after the implant being removed? After the implant has been removed? What are the problems if the implant is there and you give the flap?
So the problem with an exposed implant is the presence of biofilm, sir. So it will constantly cause infection and problem in the wound site, sir. But before that, I will discuss with the orthopedician regarding the feasibility for implant removal, sir. But if implant has to be left in place, I will give a well vascularized tissue over the implants.
What has been your experience with flaps on exposed implants of long duration?
Sir, it will result, there is a constant wound infection that is present, sir, and it will lead to sinus formation, which will take almost around 6 weeks to heal, sir, and patient will require prolonged antibiotic therapy also, sir.
The sinus formation is a later issue. What is that you have it in the initial phase before the flap settles?
Infection and flap viability is compromised.
Chances of flap losses would be high with the exposed implant.
Yes.
Better would be that implant be removed and then you give the flap.
Okay.
If other panelists have difference of opinion, they are open to express, please.
What type of muscle is soleus? Mentioned that you will do a soleus flap, right?
Yes, sir.
What type of muscle is soleus? Mathias type?
Type 2, sir.
And what is the blood supply?
It's from the.
You are planning to do a soleus flap and you don't have the blood supply on your tips.
Sir, there are three proximal, middle, and distal third. It has perforators. The main supply is from the posterior tibial artery.
And from the peroneal artery,
type
sir.
2 muscle. So it will have two blood supplies.
Yes, sir. One is
The
from the
posterior tibial and the peroneal artery, sir. The middle and distal third will be supplied by the peroneal artery perforators.
Is it described in upper third, middle third, lower third, or medial half and lateral half?
upper, middle, and lower third.
So medial half, lateral half, and in both upper, middle, and lower third.
What are the problems you anticipate in doing the soleus flap in this patient?
It is from this wound, it may be a compound grade 3B fracture, sir. So there may be a possibility of injury to the soleus muscle also, and along with it, the perforators to the muscle also might get damaged. So I will anticipate the muscle injury also in this patient.
There is also the wound is also extending to the posteromedial aspect of the leg, sir. So we do not know the depth of the laceration.
I think that appears to be an elevated flap rather than a incised wound. You already have your plan in place as to what this flap was covered with.
Perhaps this flap has presented some problem and they are trying to return it. One question, if you were to cover it with proximally based hemisoleus, are you sure that you would be covering the entire defect? Will you be able to cover
It
the
will
entire
be
defect?
difficult unless no, sir. If I take proximally based soleus flap, only the distal part of this implant won't be covered. So if at all, if I take distally based hemisoleus, it won't be that robust compared to proximally based.
With proximally based hemisoleus, which part is likely to be at risk of exposure?
Sir?
If you are to take proximally based hemisoleus, which part of the defect is likely to be at risk of exposure?
The distal part, distal 1/3 is exposed.
Suppose, imagine the incised area is there, consider it as a flap. They perhaps have planned a medial sided, inferiorly based flap, and now perhaps it is being returned for the reason of some problem. Can you contemplate another flap on the same leg at this juncture? I'll make it clear. Perhaps that flap is being returned back to its original place.
Yes.
Effect is there. Can you contemplate another flap at this juncture? Would you take that risk? Yes or no?
Sir, we could have damaged the perforator and pedicle, sir. So it will be difficult to consider in the same leg.
How would you approach this case, considering that the flap is returned back to the position for the reason of some problem of the flap? How would you go ahead now?
Then, so I don't want to injure the other blood vessels supplying this leg also. So I will consider doing.
Any issue?
You have the entire lateral aspect of the leg with you. Why would you not like to take a flap from the lateral aspect if this is not working? You can have a sural, you can have perforator, you can have propeller flaps. There's so many options from the lateral side of the leg.
So this medial aspect wound is extending posteriorly. So if it extends in the posterior aspect, I can't able to do reverse sural artery flap. So
So are you able to see the incision right now, which is extending into the sural territory? No.
No, sir.
You would assume that that territory is virgin.
If at all it is intact, I can able to take reverse sural artery flap to cover this middle 1/3 defects.
So I would like to make a point over here that you have been consistently saying that since this is an exposed implant, you want to give a well vascularized cover, you want to give a well vascularized cover. See, there is a lot of literature which is available on the use of muscle flaps as well as on the use of fasciocutaneous flaps. Now, it has been adequately and amply showed in multiple studies that the blood supply of a muscle flap as well as a fasciocutaneous flap, they both plateau in after 24 hours. Probably only till the first 24 hours, muscle flaps have got some amount of marginal benefit, probably some amount of more blood supply than fasciocutaneous flaps. So whether you are going to do a fasciocutaneous flap or you are going to do a muscle flap, both are well vascularized tissues. It appears to be from your statement that you are trying to say that fasciocutaneous flaps are not well vascularized, which is definitely not the picture. And my personal opinion is, in this case, sural flap is not going to work. Sural flap, I mean to say soleus flap is not going to work, especially a proximally based soleus flap, because you want to go quite low in the leg to harvest a proximally based soleus flap. And as sir said, in the distal third of the defect, it is definitely not going to work. The best scenario in this case would be you have ample of transposition flap options at your disposal.
Sorry to
Go
interrupt.
ahead with the sural flap. You can go ahead with the transposition flap based on the medial side. Doppler a perforator, include a perforator in the base, do a perforator plus flap. So there are multiple options, and I personally am more in favor of doing a fasciocutaneous flap. Wherever muscle flaps are avoidable, we should avoid it unless we are feeling a contour deformity, because muscles are there for a specific function. Fasciocutaneous flap, we are only going to give a aesthetic deformity. In this particular defect, even if you are going to do a muscle flap, you are going to need a skin graft. If you are going to do a transposition flap, you are going to need a skin graft. So there is no advantage of aesthetics whether you do a muscle flap or a transposition flap. So in these scenarios, your
Time is
choice should
over.
always be a transposition flap.
Okay.
The time is over for this spot.
Before we move on to can I have a
Hello?
question? Before we move on to this another slide, can
No,
we
no,
have
no, no.
consensus?
There
Can
is
we
a
have-
panelist. No.
Can we have consensus through the panelists whether
But
the
again,
intent-
you can discuss.
Okay. Okay.
No, no, no. You have a separate session, 10 minutes for each of you. You can discuss again this part during that time. Please note down because time we are fixing for each session. Okay. Yeah. We'll go for next session.
Yes, please. Let us know what is there in this.
Sure, Pratik, you
Yes,
have to identify.
Ma'am, it is a CT 3D three-dimensional reconstruction of the facial bones. It shows a bilateral parasymphyseal fracture of the mandible.
Right. How do you address this issue?
Sir?
How would you go about managing this case?
So first of all, if there is a symphysis or parasymphysis fracture, there might be a dissipation of force, so that there might be a possible injury of the condyle of the mandible. Sir, in this case, I can't able to see any other fractures in the mandible. Only
Right.
isolated parasymphyseal bilateral fracture is present.
Right.
And
how do you manage this?
Sir, I will do under general anesthesia. I will fix this fracture wound. First I will fix the arch bar fixation, but then I will intraoral approach. I will expose the fracture fragments and I will use mini plates to hold over the line of osteosynthesis on both sides, right and left side.
Intubation, do you want
Sir,
oral intubation or otherwise?
Sir, nasal intubation.
Okay.
Under general anesthesia, nasal intubation.
And you wish to put only 2 hold plates, is it?
Is it enough? There is 2 fractures, right?
Voice is not audible.
You wish to put 2
There
hold
are
plates?
2 fracture
Pick
sites.
only single plate or anything you want to add.
I will apply this arch bar fixation, ma'am. For the
That
both
has been-
mandible
That
and
is
max.
accepted.
That is accepted.
I will use single
You
2 mini
said
plates
hold
for
plate.
the individual fractures along the line of osteosynthesis.
What are they named as? What are those lines called?
Champy's lines of
Champy's.
osteosynthesis.
So here 2
Only
hold
one
plates.
line is there in this area. Do you recommend one plate in this anatomical site parasymphysis?
2 plates.
Then why you are telling one plate? Is there any reason?
Ma'am, actually there are 2 to 3 3 forces are acting over this region, ma'am.
Okay.
Tension force, torsional force, and compression force. Actually, we are placing the arch bar over the arch bar fixation, which counteracts this tension force.
Okay.
Only we have to counteract this torsion and the compression force. So in this line of osteosynthesis, there won't be any force acting over. So if we fix the plate over this line of osteosynthesis, remaining compression force and torsion force will be counteracted. So that's why I fix only one plate.
Suppose you were to do this case, would you do radical subperiosteal dissection before you put the plates on the central segment, butterfly segment?
Sorry, sir.
Suppose you were to do this case.
Yes, sir.
Okay, sir.
That you are doing it independently.
Yes, sir.
Would you do thorough subperiosteal dissection on the central fragment?
How do you approach?
Intraoral approach.
Fracture sites individually or with a one single incision?
I will full periosteum. I will strip.
I'll modify the question. How will the central fragment survive?
You want to give the total now incision. So now you tell how the central segment survive.
Ma'am, I will make an incision over this right side injury parasymphysis. I will fix it. I will open it. Then I will again open on the left parasymphysis also. Then I will identify the fracture fragments individually and fix the plate.
So you don't want to strip the central segment. That's
No,
what
ma'am.
is asking.
No, ma'am.
Feel it is not needed. If I identify this 2 fracture fragments, there is no need of exposing the central fragment because only the periosteum will supply
The
this
central
fragment. So if I injure that also, vascularity will be.
Maybe compromise, but if you strip the entire segment, will it survive or not? That is the question. Is there any other blood supply? Is it from only skin or anything from anywhere it is coming?
Ma'am, from both endosteal blood supply will be there.
The muscle
What is the muscle
but the
attached
fracture
in
is
the?
on
it
both
is
sides.
mucosa is there, muscle is there, isn't it?
Yeah.
Yes.
Yeah. Mm.
What's the muscle attached to this segment?
Mentalis, myohyalus and geniohyalus muscles are attached.
Right.
What what type of fracture mandible is life-threatening?
So this midline parasympathetic, bilateral parasympathetic, because of the pull of these muscles, there will be a tongue fall. So these respiratory compromise will be there especially in this kind of cases.
So if this patient comes to the casualty and you are called upon,
yes, sir.
What is the first thing that you will do?
First, I will maintain the airway, sir, by
Oh.
pulling the tongue out.
So you will take a tongue stitch. Especially if this patient is alcoholic with bilateral parasympathetic fracture mandible,
yes,
this patient is very likely to have a tongue fall. So the first thing that we should do in these type of fractures is go and take a tongue stitch, keep
yes,
a long silk outside so that the patient won't have tongue fall, and then go on with whatever plan of action is there.
One is tongue stitch, another is there's a small wire is there, interdental wire.
Yes, eyelet wiring.
Yes, eyelet, interdental wire, if you apply, that will be sufficient. Yeah. What type of a fracture, clinical fracture? Okay, time is over. We can discuss later.
There are questions already there, so let them answer.
Ma'am, the instrument is a skin graft handle. This is a Watson's modification of a Humvey's knife. And the parts of the handle are this handle, blade, and the ratchet for the blade. And there is a rotating rod. And there are two calipers to adjust the thickness of the skin graft. And the uses is to take the split skin grafting and also to do serial excision of the burns wound. We can take, we use this graft handles.
There is another question, modifications. What are the modifications?
Sir, initially this only the blade was non-removable blade was there. Then it was modified by this Humvees to have a rectangular shaped rod with movable, rotating, movable rod. Then it was again modified by Watson to have a removable blade along with the rotating rod. Then a lot of other modifications also there, like Paget's and all describe this power dermatomes also. Initially, first was by the Riverdin, which is used to take the pinch graft, and there are miniature versions like Silverman handle also.
How that is Braithwaite's? How Braithwaite is different from Watson's?
Sir, the difference is in the cross section of that rod, sir. In Watson, it will be a circular rod, whereas the cross section, whereas it will be in a D-shaped in Braithwaite. And the main difference is there is a advancing movement and there is an oscillating movement and a rotatory movement. So only when the oscillation and rotation is coordinated, we are able to take a full sheet of graft, sir. If the oscillation and rotation is not in coordination, then we find it difficult in advancing the blade, sir.
In rollers, the roller of the Watson's is smooth, but in Braithwaite it is serrated.
Okay.
So there might be certain areas or certain clinical scenarios where you need to harvest a skin graft repeatedly.
Yes,
you're getting my point. So in those cases, which is the site from which you can harvest repeated skin grafts at early intervals?
Medial aspect of the thigh.
No.
How does the donor site heal? That gives you the answer. You need
the pilosebaceous unit only.
Yes. So where are the maximum number of pilosebaceous?
Scalp.
Yes.
Scalp.
So scalp is the site from which you can frequently harvest split skin grafts more frequently than other areas of the body. Now, this skin grafting handle which we are seeing, can
Yes,
a
sir.
left-handed person use this harvest? How is he going to, or how is he or she going to harvest using this graft, this handle? It would be difficult, right?
Left-handed person, he can, if he is taking from the right side thigh, he can harvest from proximal to distal.
Is it? Is it possible?
From left-handed person point of view, it is possible.
Can he do that?
Ma'am?
Can he do left-handed person with this? We try to hold, imagine and hold and tell.
You try that. Imagine that you are a lefty.
Imagine.
No, sir, it is not possible.
Yeah.
Because the
So,
rod
what
will
should
be
left-handed surgeons do?
no, the rod will be in opposite side when the person is a left-handed.
So there are different skin grafting handles which have been devised for lefties.
Yes, sir.
They are available in the market.
You told serial excision by this instrument. Is it serial excision or tangential excision?
Tangential excision.
But you told serial, no?
Yes, sir. Sorry.
छोड़ता ही आ गया ना उनके लिए नहीं
So after skin grafting, the skin grafted areas tend to hyperpigment, isn't it? Especially if you have done a skin grafting over face.
Yes, sir.
Why is that so? You agree skin grafts tend to hyperpigment, especially over face. Why?
Yes, sir.
Okay, what can you do to avoid it?
What is the best way to heal our donor site?
Sir?
What is the best way to heal a donor site? You mean operatively? Will you do anything? What's the best way?
Sir, after harvesting, we will apply Vaseline gauze or dressing and leave it. We don't open it for the 14 days.
No. Yeah, if you apply collagen sheets,
Yes,
sir.
the donor site will heal very nicely and the problems are minimized. So how will you avoid hyperpigmentation? Sir was asking.
If it is a full thick graph,
Which grafts tend to show more hyperpigmentation? Split thickness or full thickness?
Can you avoid something? Avoid sun exposure.
yes, sir.
That would avoid hyperpigmentation, right?
Yes, sir.
But why does it hyperpigment that you are going to read today?
Okay, sir.
Right?
Okay, sir.
Can you take the skin graft from the abdomen with this instrument?
Yes, sir.
Can you
Yes.
take?
Have you ever taken?
We have not taken, sir, but SSG can be harvested from abdomen
The
back.
other special
Beauty-
instrument?
Dermatomes.
Dermatomes.
Specific name?
Paget's dermatome.
No.
Currently used.
Drum dermatome.
So if you have a baby of 2 days with raw area, maybe congenital aplasia cutis, how will you manage her? How will you manage the baby? I mean to say the raw area, 2 days old baby. This is a very possible clinical scenario, right?
Any method you can tell.
This is a possible clinical scenario. You get 2 days old, 3 days old babies with raw areas. What options do we have for managing these patients? Can you use a mother's graft? What are the legalities involved in it? So you can always use a mother's graft with consent, especially till the first 15-20 days, because there are a lot of maternal antibodies which are there in the baby. So eventually that is going to get rejected. There is no doubt about it. But the time frame with which it gets rejected is definitely prolonged as compared to other clinical scenarios. So what happens is that between those 2 to 3 weeks where the graft would act as a biological dressing, so it definitely helps in the reduction of protein exudation, pain, and all the other factors which are involved in it. So in these type of scenarios, you can always use a mother's graft, obviously with proper consent and understanding and explaining that it is still a biological dressing. Because 1 day, 2 day old babies, it is very difficult to harvest a skin graft with the help of a Humvee's knife, or for that matter, with the help of anything. So in these scenarios, it is better to use a mother's graft.
How many times you can take skin graft from one area or one place from the thigh? How many times you can harvest the skin graft from one side of the thigh?
We can take multiple times, sir. After
How many
certain
times?
intervals.
How many times? 5, 10, 15, 20?
What will happen if you, as you go on harvesting repeatedly the skin graft from
The
same side?
dermal thickness will get decreased and stem cells and will also get decreased.
So you cannot take so many times, isn't it? So preferably how many times?
Is it two numerical or single numerical?
Yes.
Single.
Is it 3 times, 5 times?
5 times.
Not sure, sir.
Not sure. Well, up to 3 times we have been able to, but going up to 5 times is difficult.
Okay, sir.
Maximum 5 to 6 times, not more than that.
Okay.
If it is a scalp and all, you can go for so many times, but thigh, maybe 3 times will be sufficient. And the gap between the two sessions, how long you will wait? Between two harvests, how
4
much
weeks.
time?
4 weeks.
Minimum 4. Yeah. Think time is over. The next session. Oski.
Tinel sign is elicited by tapping along.
Can you demonstrate on your colleague or on yourself?
Suppose if I am seeing for the median nerve, I will start by tapping from the distal end of the median nerve innervation, and I will go tapping proximally along the course of the nerve, ma'am. And wherever the patient will report a sensation of tingling over the distal innervation of that particular nerve. In this case, if I am tapping here and the patient is experiencing tingling over the...
Show the on your forearm. Rohit, Rohit, stop screen sharing.
1 minute, ma'am. Yes.
You correctly demonstrate stepwise how you do elicit Tinel's test.
See, you are doing it,
Yes,
no?
you told median or ulnar, whatever it may be. What will you do first?
Ma'am, we will tap from distal to proximal
end.
along the course of the nerve. The patient, if at all there is a nerve injury, patient may feel needles and pin sensation over the distal area.
Will you explain anything or no? Before doing that, will you explain to the patient anything? Will you explain anything to the patient or you
Yes,
just
ma'am,
go
yes,
ahead
ma'am.
and
I
tell?
will explain to what I'm
So,
going to do
in
to
a
the patient.
systematic way, you tell this.
Okay, ma'am.
So, this is important. That's the why we kept in OSCE question.
Okay.
Yeah.
So first I will explain to the patient what I am going to do. And I will explain the procedure and I will explain what the patient has will perceive and what I am looking for. And
Nishar is your patient.
Ma'am, we
Tell
will inform
him
the
what
patient.
what is the brief.
Ma'am, we will first
Tell.
inform the patient that we have to do this test we are suspecting the nerve injuries. So we will do the test by tapping along the course. While tapping along the course of the nerve, he may feel electric shock-like sensation at the site of injury. More at the site of injury, and the sensation will start distally also. So while tapping from distal to proximal, he may feel the more electric shock-like sensation that we have to explain. He has to tell when the sensation starts, when the sensation becomes maximum, and when this electrical sensation fades off.
How do you infer the findings? How will you infer the findings?
Oh, what is the analysis and inference you give?
We can it has two inference. One, it is whether the Tinel sign is static or it is progressive.
What is meant by static?
Static means the Tinel sign will be at the site of injury itself. It won't progress distally. So it signifies that there is no nerve regeneration. Okay. So if patient says that first time I felt this electric shock sensation proximally, now I'm feeling somewhat distally, it signifies that the nerve is regenerating and the innervation is going on. So again, we have to insist the patient that this regeneration will take this much of time, like 1 millimeter per day. So to reach the distal tip of the finger, it will take some more time. This we have to explain.
What will you call this? Where it is found that the sensations or the shock-like wave are moving, rather it's moving distally over a period of time. What do you call that?
Advancing Tinel.
Advancing, progressing, what do you call it? Okay, there is another situation. You find that on follow-up, compared to the previous inference, this time the shock wave is felt distally, yes, but at the same time, there is a lot of hyperesthesia at the site of surgery.
Repair also. So what is your inference?
Well, we can't understand the question. Our voice is very low.
You got the question? Did you understand?
No.
If in follow-up period, Tinel's is the advancing, but you get the sensation even at the repair site. So what is your inference?
Neuroma in continuity.
Yes.
Okay.
Yes.
There was another question.
For that, I would like to tell one more point before you start your tapping. You have to surface mark the nerve course. Then you explain, okay? Then you start tapping from distal to proximal, right?
Okay.
So this you have to follow.
Great. Shall we go to the other question in this?
Next
Bowier's-
question.
Bowier's test. This test I will check for the patient who has a ulnar nerve palsy, for which the patient will be having a clawing of the ring finger and little finger. Patient can't able to extend his ring and little fingers at MCP joints and the interphalangeal joints. So first, what I will do is I will stabilize the metacarpophalangeal joints. So after stabilizing of the metacarpophalangeal joints, patient will be asked to extend his fingers.
What is meant by a stabilization of MP joints?
The metacarpophalangeal joint is hyperextended. I will keep it flexed at 90 degrees.
That you have to tell.
Yes, ma'am. So if I keep it flexed at 90 degrees, if he can able to extend distal interphalangeal and proximal interphalangeal joints fully, then this Bowier's test is positive. If not, it is negative. If positive, I will do the static procedures for this patient.
What is the inference of if the PIP DIP extends on the flexion of
It is positive. Bowier's positive.
What is meant by positive? What inference it is giving?
It says that extensor tendons are lax, and because of the laxity, this interphalangeal joint extension is weak. Now, because of the clawing, the extensor tendons are stretched and laxed. So there is not extension at the interphalangeal joints. While stabilizing the metacarpophalangeal joints, this extension is possible because of this stabilization.
Anything beyond this extensor? Other reason? Any other reason?
No, sir. The joints we have to check.
So
Joints and ligaments.
If at all, is able to put the IPJs in extension. What do you think facilitates this IPJ extension?
What is the function? Which
lumbricals?
Yeah.
Intrinsic lumbricals.
What do you wish to convey through that? Suppose Bowier's is negative, what do you wish to do? You said Bowier's is positive, you wish to do a static procedure, right?
Yes, sir.
Provided Bowier's is negative, what do you do?
Sir, if the patient is not able to extend even with the metacarpophalangeal joints flexed, then we will do a T-node assist test, sir. So that we will flex the wrist and then see if the patient is able to extend the IPJ of the fingers, sir. So this will indicate that there is flexor tendon shortening. There is a component of flexor tendon shortening also that is involved, sir. Even even in that, if the patient is not able to completely extend, then we will I will suspect a joint pathology also, sir.
Now, with these inferences of through the Bowier's test, how would you modify your management?
Sir, if the Bowier's test is positive, then I will go for a static procedure, sir. But even if it is negative, then I will prefer to go for a dynamic procedure, sir.
What do you mean by dynamic procedure?
Like,
sorry, in static procedures, we do
What
only.
do you mean by dynamic procedure? What are you energizing?
The dynamic procedure is it acts on both all the joints. The tendon transfer will act on both all the joints.
Which joints? IPJs or
IPJ.
Okay. Which of these tendons, so as to say, are facilitating extension of IPJs?
Lumbricals.
Only lumbricals.
Lumbricals and introstate through the lateral band, sir.
Sir, allotted time is over, sir. We move to the next.
Yes, diagnosis, counsel, management, advantages, disadvantages of various procedures. Can you tell your diagnosis in this? Are you around?
Yes.
Yes, sir. Yes.
Only diagnosis in this.
Carcinoma of right side buccal mucosa
Involving
the commissure and involving the commissure.
Okay. If you are allowed to examine, what all will you examine? Apart from what is seen, what all will you examine?
Sir, I will examine the oral cavities, sir, for any other lesions or for any pre-malignant lesions, sir. And then I will examine the neck for cervical nodes, sir.
Okay. Do you think the mouth opening is okay in this?
Yes.
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 Okay. Suppose it is node negative.
Yes, sir.
How will you counsel? How will you manage?
Sir, if the node is negative, first of all, we will explain the patient that it is a malignant lesions involving the oral cavity. And there are possibilities that it might spread to other parts of the body like aerodigestive tract also. And nodes in the neck also might be possible spread. So I will explain that it has to be resected, removed, and we will send for the tissue biopsy. It will tell whether it is more aggressive or less aggressive. It will tell. And if at all there is a node present, we will take some FNAC from that node also, and we will
node negative.
Node negative. Then we will say that that only the lesion is present in the oral cavity, that we have to send for the biopsy and we have to check whether it is highly malignant or not. Then other parts of the body, this might have spread like aerodigestive tract, or there is another second lesion which might be present in the aerodigestive tract, which I have to check.
There is no second lesion, no metastasis. Only lesion that is there is this, and it's node negative. You are counseling.
Yes.
How would you proceed? How would you manage this case?
Won't you tell where you are going to take the flap or regarding facial asymmetry, anything like that?
Sir, first I will tell the patient that there will be this has to be excised with margins, and hence there will be a defect in the oral mucosa as well as involving the commissure and the skin, sir. Depending upon the induration or depth of invasion, we might have to remove the skin. I might have to remove the skin also, sir. So I will tell him that there will be a defect of this size, and that has to be resurfaced with the skin, sir. So skin and mucosa has to be replaced with the replacement of the commissure also. So I will prefer to do a laterally based folded forehead flap for this patient, sir.
Okay. Suppose in this case, skin also has been removed. Would your laterally based forehead flap enable cover of skin as well?
Yes, sir,
Yes,
we
sir, it
can
will
give
be
it
folded.
folded forehead flaps.
Folded forehead flap to provide resurfacement of the mucosa, the commissure, and then the skin as well.
How you want to plan it?
So in the first instance, are you sure that the forehead flap will enable provision of skin cover as well?
Standard forehead?
Yes,
Or
ma'am.
Yes, ma'am. Standard
any
forehead.
modification?
Any modification? Will the length and reach will be sufficient if you take a standard forehead?
Yes, ma'am, it will be sufficient. It will be based on this one-sided superficial temporal artery. So it will be sufficient, and it can be also folded to reconstruct the commissure and both the linings.
Have you heard of extended forehead flap?
So what is the limit of standard forehead? Where will you stop? So sir is asking extended forehead. So what is the limit of a standard? What is the limit of a extended?
The distal part of your forehead flap, is it going to go in the mucosa or is it going to come in the skin?
Distal part for the mucosa.
So are you planning to take your forehead flap above the skin, or you are going to tunnel it above the zygoma or below the zygoma?
As a pedicled forehead flap, sir. Above
Yeah,
the skin.
pedicled forehead
Above the
flap.
skin.
Above the
Both are
skin.
pedicled.
So you will be dividing it at 3 weeks.
Yes, sir.
Any other options? Single stage?
Free radial forearm flap with the palmar longus to reconstruct this commission.
Before we go to that, imagine in the same case, skin is involved, a considerable portion of cheek skin is lost. Rather, it is involved and it would have to be sacrificed. If you are planning forehead, how would you modify this forehead to enable cover of both the skin and the mucosa?
We can take a bilobe. I will take a bilobed forehead flap, sir, based on both the frontal and parietal branches.
What is the name?
Narayanan flap.
Suppose in this case, imagine if it had been node positive and they have done radical neck dissection. Would you still go ahead with Narayanan flap?
Yes, sir.
Suppose
What is the disadvantage?
in this same case, if it had been node positive and the oncologist has done radical neck dissection, would you still contemplate and plan and do a Narayanan flap?
What is the problem if you plan this flap when neck dissection is done? What all you remove in neck dissection?
Level 1 to 5 nodes, ma'am.
Agreed. Apart from node, what else do we remove in radical neck?
Submandibular gland.
Radical. You listen what is asked. Radical neck dissection means?
Sternomastoid, interjugular vein, and
spinal
spinal
axis.
axillary nerve will also be removed.
Now, will you still contemplate doing Narayanan flap, having had the internal jugular removed?
Venous.
Yeah.
Venous problem.
Venous problem.
Right, madam was asking other plans for this.
What are the other options? Go ahead. You told one is radial forearm. What are the other options? Time is
Right. Radial forearm free flap. Second option.
We have 1 minute more, ma'am.
yes. Only one.
Then PMM pectoralis major percutaneous flap.
Any modification or a single because the skin
With
and
the skin pattern.
called.
No, if you have to bring it, you have to bring it onto skin as well, cheek as well.
Cheek
I
as
mean,
well.
With the skin paddles.
Oh, by
Zeocutinins.
yeah, bipedal.
Bipedal.
Yes, ma'am.
Yes. What else? You should tell that area. So many flaps are there. So
Deltopectoral flap.
only the deltopectoral.
Will you take deltopectoral into mucosa?
Both.
Ma'am, what skin for skin lining, deltopectoral, and for mucosa we can have a forehead flap cover.
On whose names do they go? The deltopectoral and the pectoralis major.
PMMC.
On whose name does it go? PMMC and the deltopectoral.
Names. Who described?
Ma'am, deltopectoral is described by Bakamjian.
Yes.
Fine. Pectoralis major.
Pectoralis major.
Have you heard of Adrian?
Okay.
Adrian flap. Suppose bone is involved.
Yes, sir.
Okay, we are going on to the next question. Right. Okay.
Time is over. So just diagnose and tell regarding the documentation.
Question is, how will you document all the aspects related to this injury?
What it is actually?
Electrical burns injury involving bilateral hand, abdomen, and chest wall.
I will document the time of injury and the type of electrical burn injury, the source, whether it is high tension or low tension burn, and the
What
time.
you feel with the findings? Okay. Proceed.
The findings are the patient has full thickness burn injury over the right chest wall in the anterolateral aspect, extending up to the axilla and also to the anterior wall of right abdomen. And patient has gangrene of all the fingers of left hand, extending up to the distal forearm level. And also patient has an eschar over the right distal forearm, which is circumferential, extending up to the ulnar border on the up to the proximal third on the ulnar border.
From the history also, I will document the electrocution mode of this electrocution, whether he was actually holding this electrical wires or he was holding some other iron object like arc lightning injuries, and whether he was standing in a height, whether after electrocution he fell down. So such kind of histories I will ask, and I will look for the both contact wounds like entry and exit wounds. I will look for. Then
will you be able to salvage the left hand?
Not. Sir, left hand I can't able to salvage, sir. It's already gangrenous. Right hand there is an scar present over the distal forearm. It might go in for compartment syndrome. So emergency fasciotomy I will do for the right hand to decompress so that it can be salvaged. Right hand we can salvage, left hand we have to do amputate.
The wound on the right wrist and distal forearm, it seems to be involving almost 2/3 or little more than 2/3. So how would you ensure provision of skin cover?
Sir, this electrical burns injury is there is an scar, but the high possibility that it involves the deeper tissues also, sir, because the tendons, nerves are also might get injured. So whatever the structures have been injured, I have to excise and I have to reconstruct later, for which I have to give a cover over the dry area. I will do superiorly based abdomen flap cover for that defects.
Will you be able to cover 2/3 of this circumference with superiorly based abdominal flap alone?
So the exposed region is over the tendons are exposed more.
It's almost 2/3 area involved.
Yes, sir. I will do abdomen flap cover. At the time of division, I will use the flap. Insert will be given to the entire circumference.
How
So
about the
in the first initial stage, I will give insert only to this overall aspect and more on the radial border cell. At the time of division, I will give insert to the ulnar border.
Are you aware of something called bucket handle flap from abdomen?
So both superiorly based and inferiorly based flaps, abdomen flap can be given, sir. For the volar side, superiorly based, and for the dorsal side, inferiorly based abdomen flap can be given.
Instead, just place it under a bucket hand flap, and later in stages, adapt delays separately for superiorly based flap, and then separately another few for the inferiorly based. Okay, how about the chest wall?
Bipedical flap. Okay.
Right.
Superior
Right.
contact will be there, inferior contact. You will pass the hand underneath the flap, and later on you will superiorly and inferiorly do the delays. Okay.
How about the chest
Or
wall?
there are flaps like groin hypogastric to cover the both, and paraumbilical also you can take a large flaps.
What is the legal implication of documentation as an expert in medical legal case? How do you stand in the court of law on favor of the patient or in the against the patient also? Your documentation will be important in there.
What will you do when any case like this comes? First thing what you should do?
I will admit the patient. I will make a AR entry.
Yes.
Medical legal.
Medical
Number.
Yes.
MLC number.
And even you have to inform. See, so many wounds, high voltage electrical burns, isn't it?
Yes, ma'am.
Will you assure the life of the patient?
No, ma'am.
Then what you are supposed to do?
Then, ma'am, we say we will also explain that only the we can able to see only the external injuries. There are high possibilities that there are cardiac problems also will be there, and
in the court of law, as an expert, what you have to brief? And before that, counseling, how you will do it to the patient? What you will tell that it has to be, this part has to be taken off. Otherwise, your life is at risk. So those consents are very important for doing an amputation. What type of amputation you will be contemplating in this patient? That left limb, no?
guillotine below elbow, guillotine amputation of the.
Why you do guillotine?
Sir, we can't be sure that the skin viability of and tissue viability of that left forearm, sir. If we close the stump, we don't know how much skin will be viable, or it may get progressively.
Skin or some other tissues which is affecting electric burns and nephrotoxic problems. Which tissue is mostly affected? A later on patient will have a nephrotoxic. Yeah.
Yes.
So that you have to explain in documentation. And in court of law, you will be asked for an expert opinion that why you have done an amputation. How you will explain it? What is your documentation evidence based?
Sir, I will say that the hand is not viable because it is gangrenous and there is no
So
movement.
you
There is
should have
no
a good
pulse.
photograph. Patient should have a good photograph of all the parts of involvement.
Okay, sir.
So that will help you. With the better ticket, you have a schematic diagram of all the documentations. And while doing a amputation, what consent you will take from whom?
I will take consent. If patient is unconscious, I will take consent from the close relatives. Like if he has wife, I will take consent from his wife.
And one doctor will give consent, or minimum 2 doctors are required. And one orthopedic surgeon has to be involved for a consent. Because should be a plastic surgeon do a amputation, or orthopedic surgeon will do? Who do the amputation in this case?
We do the plastic surgeon do the amputation.
No. Amputation has to be done by orthopedic surgeons.
Okay.
Sir, most of the centers, plastic surgeons only doing, sir.
You are doing it.
Yes, sir. Electrical burns, especially, we are only doing.
Even at
Okay.
Gandhi.
But how do you take a consent for doing
Like
amputation?
2 members, if they have the 2 plastic surgeons can give the things, sir. So
Okay.
consent is taken from all the relatives and from thumb impression of the patient. As a team in teaching institutes, more than 2 faculty will be there in unit.
Yeah, that is true. That I accepted. But
Electrical burns, we are only doing the amputations. They are not doing. But if they want amputation for a traumatic limb, they definitely take our opinion.
Okay.
Reverse
It all
is
depends.
happening.
It varies from institutions.
Yes,
No
sir.
problem. Yeah.
Depending on the load and how
Yeah.
they ask. So we are doing.
So
And
this
one
is very
more thing, the DD, you have to inform the concerned police through the hospital administration or you yourself and arrange for the DD also. Okay. So you should mention whether the grievous injury, simple injury, all these are in systematic way should go. Okay. You are
So once you
mainly, you mainly concentrating on the clinical aspects. So we want these other aspects also to be regularly documented. So that is the one reason why this documentation is added in this session. And video consent. Nowadays, there are so many problems. So the critical cases always you better you take a video consent. Okay.
absolutely correct. But the patient wants something after the amputation. As a consultant in plastic, should you advise for something?
That also you have to.
Huh?
Upper limb
Hello?
process.
Yeah. Upper limb prosthesis, you should advise, because end of the day, patient comes to you first. So obviously your terms will be better with the patient. So you should have a upper limb prosthesis. Good prosthesis are available that can be given also. In this context, what Ganga prosthesis is there for the hand? What Ganga has devised a prosthesis for the hand, especially magnetic prosthesis.
Okay.
Do you know about it? Okay, it is out of course syllabus. I am not, for that you are not evaluated. Please don't mind. I asked for that. So there is a magnetic hand like prosthesis. The Ganga has developed, Ganga Hospital. Okay.
Okay.
Imagine in this case, your attempts at salvage of the other hand. See, one is gangrenous, you are amputating. The other hand you have attempted, but you have not been successful. It also has ended in amputation. What would you do to facilitate some function in that?
Then
Both hands are amputated, sir.
Yes. Is there any way that you enable some function? I'm not speaking about prosthesis.
Hand transplant.
Anything before you attempt that simple method. Have you heard of Krukenberg's procedure? No. You try to facilitate some function, provision of some function by having two pores. Krukenberg's amputation. Have you heard about it?
No.
You do it in a way that there is one radial and small ulnar pore.
Yes, sir.
Acts like a
using
fork.
a fork.
Acts like a
Fork.
fork.
Yes, sir.
To hold the objects.
Nobody does it.
Nobody does, but it is described.
Nobody does.
So
Describe.
how
Some
to
old procedures.
about it.
And the advent of the beautiful process, we don't do it.
Yes. Now all sessions are complete. We invite the panelists one by one to give your analysis of our PG team presentation and give suggestions for their improvement and tell your opinion about Plastiquest. We invite that.
So shall I start?
Madam,
sir?
this.
Sir.
Can I start first?
Yeah, sir wants to talk.
Ramanan sir, do you want to speak to begin with, or?
Yeah. You please start, sir. I will follow you.
I felt like that they were very good in zone 2. And then coming to the spotters, exposed implant is one.
Video,
Am I audible?
Yes, sir.
Yes, sir.
Yeah, yeah.
Right.
Rohit, please press. Yeah.
As regard to
Now you
exposed
can.
implant, exposed implant with the compound wound, I felt they could have done much better. And management in the presence of exposed implant, it's always debatable. But I feel that as postgraduates, we teach them that the implant be removed first and then the flap cover be given.
But it has to be stabilized with X-Fix.
X-Fix, yes, I understand that. Yes. Regarding other spotters, yes, they have done well, excepting some few questions like hyperpigmentation of the grafted areas. Cheek malignancy, they could have done much better. Rest all is quite okay for me. And the Plastiquest, thank you, Lakshmi, for involving me in this. I feel that this is quite interesting, and perhaps it involves a lot of labor coordination from you. And I appreciate all those who are in this organization. That is from my side.
Thank you.
Thank you, sir.
Shall I start, madam?
Yeah. Yes, sir.
Yeah, I should appreciate both PGs. They were very bold and they didn't stare at any question and they were able to answer very well. And the overall performance is good. It's more than enough for a pass. And only find a very minor flaws, as he has said about the leg defects, they could have done better. Otherwise, most of the questions they have answered very well, and beyond their they are done. And I think it's a good platform for all the PGs to learn. I think every medical college should participate in this Plastiquest, I believe, madam. It's a wonderful platform. PGs can really learn very well. The various questions have been put forward by both the panelists as well as the medical college PGs also. So constant attention is needed. So you cannot miss anything. Once you attend one session, it's enough. I think you can learn thoroughly. Very good, madam. It's a wonderful experience for us, and I appreciate all your efforts and your team. Thank you.
Thank you, sir. Nikhil, Dr. Nikhil.
Yeah. First of all, Nisar and Ritika very well presented and very well performed throughout this duration. I would like to state here that there are a lot of gray zones in plastic surgery. There are a lot of debatable factors. Some would say from this side, like they would be favoring muscle flaps. Some examiners would be favoring fasciocutaneous flaps. Some would be favoring free flaps. Some would be favoring pedicle flaps. So there are no right or wrong answers, especially when it comes to decision making. So what I want to say here is you should be completely sure of your concepts, and you should be able to defend your thought process very boldly. So if you are sure of your principles, you should be able to do that very comfortably. And I think you performed really well today. I think you need to read more of basics, especially you coming from Stanley. No question of hand should be unanswered from your end, especially the basics regarding sensations, 2-point discrimination. That is because you come from Stanley, that is unacceptable. You need to know each and every bit of hand surgery. I believe that is there. But overall, performed really well. Lakshmi Madam, I would like to thank you. This is a huge task that you have undertaken. And here I would like to categorically state that starting anything is very easy, but to keep on doing it consistently over the years, which Madam has been doing, is a really tough job. It takes lots of efforts, and hats off to her consistency and the efforts that she has been taking to organize Plastiquest since I believe past more than 3 years, 4 years. I think this has been an ongoing activity, and the main advantage for the students, I believe, is you get an exposure to faculty and examiners across India, which probably before 4 years you would have never thought. You just get exposed to your faculty in your own institute, and you know only what questions they ask repeatedly. And each faculty has got their own fixed set of questions, beyond which even our question sets are limited. But when you get an exposure of faculty and examiners across India, so that is a big advantage. And I think all thanks to Madam for taking up this initiative and pursuing it thoroughly. So I think that was all from my end. Thank you. Thank you, Madam, for having me.
Thank you, sir. Thank you very much. Dr. Ramesha?
It was a very good program, madam. Students did very well in hand. They answered most of the questions, and other majority of the sessions were they answered well, except the leg and the other broader concepts are required. But other they were very good, madam. And the Plastiquest is a good learning process. Thank you, madam, for making me part of this. Thank you.
Thank you. Thank you. And most of the faculty from across country, they are sharing their clinical material for the Plastiquest. I really thank all who are participating, contributing, and accepting immediately when we invite. So thank you all the panelists. It's a wonderful discussion today. Rohit,